So yeah, so for the I'll have a few slides where we'll have some multiple choice type questions and a little space to annotate. And so what I would recommend is actually using the stamp feature. I think it looks like a little check mark. You can choose whatever stamp you want. It doesn't matter. And just for practice here, you can put in your vote on this to say who's going to win the women's championship. Is Caitlin Clark just going to be unstoppable over here? We'll see. Okay. Oh, okay. Very
And
good.
Ram, if you're able to turn off the annotators' names, I
How
think
do I
that
do
was the
that?
preference. And I
Oh yeah, I see. Hide names of annotators. Got it. Okay.
Great.
All right. You won't be embarrassed by your choices here. Okay, good. So everything looks like it's working here. Great. So we'll use this stamp feature going forward here. Let's see. Okay. Okay. All right. So Kate, do you want to present the clinical history for this first case?
Great. Yes, thank you. Now I need to move this out of the way. Yeah, so this is a veteran that I saw in clinic. She's a 68-year-old woman with a history of a liver transplant in 2021, and she was referred to kidney clinic for elevated creatinine and albuminuria. So just a brief history. I'll start out with the point of her liver transplant. In 2021, she received a liver transplant for alcohol-related cirrhosis. The course after her transplant was a bit complicated. She had several admissions, including for CMV viremia, colitis. She had an episode of neutropenia and cellulitis, and also an episode of transplant rejection. Um, During all these admissions, she had several episodes of AKI, as might be expected, but they largely resolved. And by about the winter of 2022 to 2023, she was feeling quite well. She felt like most things had kind of settled out, and her creatinine was 1.2. There was a bit of a gap in her lab follow-up. She tells me that nothing particular was happening at that time. She was feeling well, but just didn't have routine labs. And then her next labs were in September of 2023. And her creatinine was noted to 2. She had 2+ proteinuria on her UA, which prompted a 24-hour urine. And she had 3.3 grams of protein on that 24-hour urine, so was referred to kidney clinic. So a little bit more of her past medical history. Mentioned her alcohol-related cirrhosis. She also had HCC and had a TACE and then the liver transplant. She has severe mitral valve stenosis related to calcification, hypertension, and a few complications of the medications after her transplant. She got osteoporosis and steroid-related diabetes. The medications when she presented to clinic included TAC. Her goal has been 3 to 5 at this point post-transplant. She's on some antihypertensives, amlodipine, metoprolol. Alendronate was started for her osteoporosis. She's on omeprazole, aspirin, and magnesium supplement. She lives with her husband. She exercises daily, really robust woman, no alcohol or other recreational substances since her transplant. And she tells me no history of kidney disease in her family. So on exam, her blood pressure is a little bit high in the 140s. She says, 130s or 1 to 140s at home, but she looks really great. She looks like she's doing well. She's euvolemic, no edema. She does have a pretty prominent systolic murmur, but otherwise her exam is pretty benign. These are her labs, her most recent labs on the presentation to clinic. I noted her creatinine. She also has hypermag, probably related to her supplementation in the context of AKI, and a hemoglobin that's been pretty stably low. Looking back a little bit at the trend of her creatinine and proteinuria, like I say, there's a bit of a gap in information from November of 2022 through the summer when she presented. But looking back, you can see she had some episodes of AKI. The first or most recent negative protein UA that I could find was back in December of 2021. And then she had a positive UA in December of 2022. some subsequent labs that we got to better quantify her protein. Her on repeat in October, her creatinine was stable, ACR 2.7, protein 3.5 on a spot. So before we go into serologies, Ram, if you would like, we can pause, or we could just review serologies.
Yeah, that's fine.
Whatever you think. Yep, that sounds fine. So her tacrolimus levels have been 5 to 7. There were a few episodes where they were a little bit higher, but mostly before her creatinine elevation. Markers of hemolysis were unrevealing, autoimmune panel, monoclonal gammopathy, notable for a very small gamma protein, and that was lambda. Viral panels were, or viral serologies were unrevealing, and she had an ultrasound that had maybe a little bit of an asymmetric look to her right and left kidney, but otherwise nothing prominent.
Okay. So thank you, Kate. So thoughts, ideas. So complicated medical history with the liver transplant, some AKI episodes that seem to have resolved, and then now a persistently elevated creatinine and proteinuria almost in the nephrotic range. Um,
What's her ethnicity?
She's a white woman.
And then no hematuria, right?
No.
okay. Any thoughts? What might be going on?
I think I'm going to go with collapsing glomerulopathy from alendronate or plus minus tacro.
Plus minus Dacro. Okay. All right. Other thoughts? We're going to go with a laser focus to collapsing glomerulopathy. Okay, let's see. So I'm going to switch here to the live screen, live slide here. So give me a second. Let me find out the right screen. Okay, so now you can see hopefully you can see the actual biopsy here.
Yes.
So yeah, so let's take a look. So at low power, we can see we've got a nice core of renal cortex. So here, this little black area here is the kidney capsule. We can see even at this low power, there are some vessels over here. And as we start zooming in, we can see that it's not a pristine looking kidney biopsy. And what I mean by that is that there are areas that are kind of more gray in color. Rather than having lots of pink tubules everywhere, we're seeing some tubules that are kind of more shriveled up. This is associated with some inflammation, which is kind of a little bit chronic and active in appearance. Perhaps some even acute tubular injury as well. Some of these tubules have a little bit of attenuation, more white space in there. Abal is already looking at this glomerulus and trying to, see if he's right. So far, no, but we'll see. But this isn't a completely normal looking glomerulus. There's a little bit of extra black material here. And so I'll just have you think about what that might be. So scrolling around, we can see again, okay, there's some more chronic injury. Again, just for reference, these are the normal tubules over here, nice and pink, filling the lumen. Whereas some of these tubules over here, you can see that they're not quite back to back, meaning their basement membranes are separated, and there are inflammatory cells, some chronic appearing inflammatory cells in the interstitium, some cells even infiltrating into these partially atrophic tubules. When we look here, we have an artery over here, maybe a touch of our intimal sclerosis, arteriosclerosis over here, but overall not very a bad looking vessel over here. You can see here's a completely sclerosed glomerulus. It's basically like a little black ball of matrix. And this atrophy that's of the tubules adjacent to it is likely related to this glomerulus. So the nephron is, of course, geographically organized. So once the glomerulus dies, then the downstream nephron, the tubular portions of the nephron are also going to atrophy, and that's probably what we're seeing in this kind of geographic pattern over here. So let's keep going along and see if we see some other features. Okay. Let's see. Okay. So I think we have some more glomeruli over here. Let's take a look over here. Okay, let's see. So what do we have over here? Do we want to, let's see if the annotation actually works here, just for my own reference. Which glomerulus looks more abnormal? And where is it abnormal, if you want to put your stamps on the thing? Okay, see one check mark. Ah, okay, I see a nice circle. Who is the purple circle? Do you want to tell me what that is? Okay, so the
Oh,
purple
sorry.
circle person is going to remain anonymous.
Well, actually,
Interesting.
sorry, that was me, Maggie. I didn't
Oh,
mean
okay,
to do
Maggie.
a circle,
You got it. You got it. Okay,
but
that's great.
I meant to do a check, but it looks very, are those thrombi or it looks very vacuolated?
Right.
Yeah.
Okay. See now, how do I clear the annotations here? Okay. So you have the right area that is abnormal in this segment of the glomerulus. And it's not really thrombi, but it's actually some hyaline material, this pink material,
Yeah.
maybe even a foam cell here. And we're not seeing white space of the capillary luminum. So just for reference, here's some white space patent capillary loops. So there's a little area of segmental sclerosis. Okay. So we have, at this point, we have FSGS. So maybe that's the cause for her proteinuria, right? So pretty boring case so far, right? Um, okay, well, we'll keep looking. We look at everything. So what's going on here? So Abal had to kind of be too smart and actually tell us what's going on right at the start of the case, but that's okay. But yeah, we have a glomerulus which has kind of a collapsed look to it and a prominence of the overlying epithelial cells over here, some of which have these little protein reabsorption droplets, so these pink globules in there. So, and we may also have a kind of an evolving conventional sclerosis, segmental sclerosis over here with some hyaline deposition here and here as well. So, so far we have FSGS. At least one of these glomeruli has a kind of a collapsing appearance to it. And we have, a decent amount of chronic injury with sclerotic glomeruli, tubular dropout and atrophy as well, and just mild chronic vascular disease. Now, we didn't see anything that looked like actual thrombi anywhere in this biopsy. And so we were just thinking, okay, well, the patient has some risk factors for a collapsing glomerulopathy. Abal mentioned the bisphosphonate exposure, but the patient also has tacrolimus on board. So could it be one or the other? We didn't see thrombi here, but let's continue. All right, so let's switch back to the regular PowerPoint. Okay. All right, so just quickly reviewing here, we saw some abnormal glomeruli, okay? So I pointed it out that here's another one with a little bit more prominence of those changes. But how would you describe the changes, the lesion that you're seeing in this glomerulus? And there's a little space underneath each of these terms. If you want to put your check marks or annotation stamp in that region, we'll see how the audience polls, and then we'll discuss what's actually going on here. Okay, all right, good. So we have the majority of the votes are going for segmental scarring, and there might be a touch of segmental scarring, but I'm still seeing patent capillary loops out of the periphery. So this is mostly in the mesangial sclerosis kind of category. And thankfully, no one said endocapillary hypercellularity. Now, remember this patient also had some diabetes associated with it. We are also thinking, could there be nodular changes if there's some chronic vascular injury, perhaps related to tacrolimus? We see maybe some irregularities at this higher power of the capillary walls with some thickening and duplication. there's some more kind of mesangial coarsening or thickening, both with matrix and increased number of cells in these segments as well. So kind of a complex kind of question, mostly mesangial sclerosis, possible segmental scarring in this glomerulus as well. Okay. All right, so just another glomerulus that I didn't show you on that particular section. This has segmental sclerosis. This has got a little foam cell over here, another capillary loop that is kind of accumulating matrix and kind of occluding the capillary lumen. And here again is that glomerulus that we saw with collapsing features. Now, when we started looking at the immunofluorescence, it was negative, except for just a very little amount, kind of trace granular IgA staining. And this was not enough for us to think about IgA nephropathy, but we wondered, given that history of liver disease in the past, whether this was related to her past liver disease that hopefully is fixed after her transplant. So going to EM, here now we can see maybe some granular electron densities, not a lot, in the mesangial regions. So just again to orient, these are kind of the mesangial regions over here. You can see the capillary loops kind of over here with their lumen over here and the podocytes on the outer side, the urinary space. We can see that there is some effacement of the podocytes. Over here, instead of seeing discrete foot processes like you can see over here, they're kind of all flattened out over the capillary basement membranes. So we have a correlate already for the FSGS and proteinuria here, and not a lot of immune deposits as we might, which kind of matches what we were seeing by immunofluorescence. However, even here, we start seeing some irregularities. There's some loosening over here, maybe over here. We'll take a look over here as well. Here are a couple of more capillary loops with some effaced foot processes. And I'll go ahead to this view. Here you can see a capillary basement membrane over here, podocytes on the outer aspect, the blood, the vascular space over here. So just from this picture, what do you think is the best term to describe these findings in this image? One vote for podocytopathy, some subendothelial space widening. Okay. Okay, good. Now the votes are coming in. Good. So yeah, kind of a little bit of both things, right? So we have some foot process effacement for sure. Whether that's primary or secondary, who knows, right? But we can certainly see that there's some injury response in the podocytes, but also very prominently the subendothelial space. So again, as a reminder, here's a red blood cell, so we know we're in the capillary lumen. This is an endothelial cell nucleus. The cell and the cytoplasm should be sitting smack against the basement membrane, but instead you can see that that subendothelial space has been expanded. There's all this kind of laminated, kind of poorly organized material, maybe some new basement membrane-like matrix. There are even some cellular processes that have kind of worked their way into that expanded region. And this kind of correlates with that segmental thickening and duplication of basement membranes that we were seeing by light microscopy as well. And thanks for that check mark over there. So as you can see this, the diagnosis is not super complicated, at least at the top line. We have FSGS. It has some collapsing features, and we speculate, could this be related to bisphosphonate? Though the patient also had tacrolimus on board. So that's a question as to whether that is also contributing to the collapsing glomerulopathy. And related to TAC, we also have evidence of some chronic endothelial injury. Definitely by light, but more prominently by electron microscopy with the remodeling of the subendothelial spaces. And the question is, which one of these, or are both of them, contributing to the changes that we're seeing? That nodular changes that we were seeing in the glomeruli, the question is some of the diabetic kidney, is this some version of diabetic kidney disease for this patient? Or could this also be kind of a chronic TMA-like picture related to tacrolimus that is causing some nodular changes in these glomeruli. And so kind of a complex medical history, also a complex kidney biopsy here, but at least we have a cause for we have an anatomic reason for the proteinuria. The question is, what is Kate going to do?
Well, I was thinking along, I think it took me probably more than the 5 seconds that it took a ball, but we had a similar differential starting out and of course removed her bisphosphonate right off, although tend to think of this FSGS or collapsing FSGS associated with bisphosphonate more for IV bisphosphonates, and this was an oral bisphosphonate, but the timeline was pretty consistent. She started that bisphosphonate just before that kind of gap in labs. And then, worked on her blood pressure control and have spoken with the transplant surgeons down at Portland VA. We're at this point just keeping her tacrolimus level as low as, clinically appropriate. Haven't decided to switch agents yet. Her creatinine in follow-up has stayed pretty stable, but it is encouraging to see that her albumin creatinine ratio, just with either time or the interventions that we did there, is dropping as of yesterday. But happy to have any other thoughts on whether we should be more aggressive about removing her tacrolimus or otherwise.
Okay, thanks, Kate. So just briefly, just wanted to talk about, collapsing glomerulopathy. Of course, we think about it as an aggressive type of FSGS, but yeah, and it has many, many associations with it, and bisphosphonates are one of the potential agents that are problematic for these and causative or potentially causative in collapsing glomerulopathy. So I pulled this old study out from almost 25 years ago, which originally described the association of bisphosphonate, in that case pamidronate, and glomerular disease. Since then, bisphosphonates have been associated with other forms of injury, just regular FSGS, even minimal change disease. And you can see from this initial description, collapsing glomerulopathy was kind of the most common pattern, at least on biopsy. Now, of course, patients who are on bisphosphonates may get acute kidney injury as well. Not all of these patients are biopsied. In fact, maybe even the predominant injury to the kidney may be tubular, but at least this is association in terms of the for-cause biopsies that are done in patients with bisphosphonates, FSGS, especially the collapsing variant, has been associated with it. In this kind of meta-analysis a few years later, now this is in 2008 by the same authors, they were able to kind of look at this across a number of studies and case reports to kind of synthesize what are the features. And again, we can see collapsing FSGS as kind of a recurrently reported, though there are other forms of glomerulopathies that are also associated with it. As Kate mentioned, there is kind of a weak association that the bisphosphonate withdrawal in some of these patients is associated with improvement in the proteinuria, sometimes serum creatinine, but in other patients, it does not seem to help. And so it'll be interesting to see in this patient as well how that goes long term. Okay. So I just wanted to briefly just introduce this concept. So this patient was, I think, almost 68, 70 years old. And so as we think about collapsing glomerulopathy, at least my understanding and thinking of it, it continues to evolve. And I don't think we should be thinking about this as a single disease. And so this has been reported recently by our former fellow, Nicole, who's now at OHSU, and also by, I think, Barry Stokes earlier here as well, that there seem to be different forms of collapsing glomerulopathy. For example, older adults, these individuals tend not to have as aggressive proteinuria. They may have other comorbidities, especially chronic vascular injury or chronic parenchymal injury in general. Not a strong association with viral infections or even APOL1 genotypes. So there might be kind of a vascular contribution to the injury to the glomerulus as well. And this is kind of borne out when we've done, spatially localized transcriptomic studies as well. We can see in patients with, COVID or HIV, especially those, for example, with thrombotic microangiopathy and endothelial driven injury to the glomerulus. There might be a loss of the endothelial signal with retention of podocyte signal. Whereas in other patients, there might be loss of all three major cell types in the glomerulus, or in some patients, even selective loss of podocyte signatures with the retention of the glomerular endothelial cell signature. And so that has really kind of led us to think about, whether there might be kind of a podocentric and a endothelial-centric causes for collapsing glomerulopathy. And of course, all of these are multifactorial with both genetic and environmental risk factors as well. And that hitting one or the other, sometimes some agents hit both of this axis, can actually lead to an acute collapse of the filtration barrier and that collapsing features that we have seen. So this is just some of the things that we're thinking about. Now, the question might be, how can we actually test that? And so we've been thinking about some of the tests we can do in the laboratory, where we have noticed from our studies that there can be loss of podocyte signals. So they lose expression of their canonical marker genes. And likewise, there could be loss of endothelial cell signals as well. And that might be a way to get us a clue to see whether it's either the podocyte or the endothelial cell that's the primary target in the pathology that we're seeing. So one way that we've explored this is by looking at, say, for example, two markers that kind of go in opposite directions. So PAX8 is not normally expressed by podocytes or cells within the glomerular tuft. You can see here it is expressed in tubules and some PEC cells. But under conditions of collapsing glomerulopathy, where we think the podocyte is the primary target, there's expression of PAX8 on the reactive epithelial cells on the collapsed tuft. Conversely, podocytes normally express MME or CD10 antigen. And again, with injury to the podocyte, we see loss of that signal in the collapsed glomeruli. And so these are just markers to suggest that these might be the podocyte as the primary target in these injury processes. We're exploring other markers for the vasculature as well, but these are still a little bit early days. So I just want to quickly flash this case up as well, where we started to evaluate this. Now, this is an older individual, 83-year-old female, who presented with a nephrotic syndrome and also some AKI as well. So again, remember with the collapsing glomerulopathy or collapsing FSGS in older adults, it tends to be not as heavy proteinuria and more vascular type of picture, potentially contributing to it. So this patient had kind of very classic looking collapsing glomerulopathy, had some degree of foot process effacement, though it wasn't, extensive in this. And we asked, could this, even though this is an older patient, it didn't quite seem to fit the vascular injury pattern. Could this be a primary podocytopathy in this patient? And so when we actually tested for loss of CD10 staining, we saw that in fact there was loss of MME on the tuft, suggesting that this might be a more podocyte intrinsic kind of injury process rather than the chronic vascular injury process that has been associated in aged individuals. So I will stop there with the first case. Any questions before we switch to the second case? Okay, all right. So let's get started with the second case. This is together with Dr. Watford.
Hi, everyone. Good morning, and thank you for tuning in. Some of you guys may be familiar with this case, particularly over at Montlake, as I just discussed it at one of our professional round conferences this week. So bear with me for the redundancy, but I think it'll be very nice to review the pathology. So this involves a 34-year-old gentleman with past medical history of ESRD secondary to IgA nephropathy. He was on PD for approximately 6 months. He made normal amounts of urine. This is a transplant case, of course. He made normal amounts of urine pre-transplant. No other significant past medical history other than related to his ESD, KD. He had hypertension, hyperlipidemia, and some anemia of chronic kidney disease. He was blood type O and 0% PRA going into the transplant. He ultimately received a blood type A2 living unrelated kidney transplant in October of this past year that was facilitated by the National Kidney Registry. Just prior to his transplant, he had anti-A titers that were checked on 2 different occasions that were below our threshold to proceed with A2 to non-A kidney transplant of 1 to 4 in both June of 2023 as well as September 2023 prior to proceeding with this transplant. Of note, the donor was a healthy 40-year-old female. The organ came from Florida due to the NKR exchange. There was some notable size mismatch of the donor being about 60 kilograms and the recipient being about 95 kilos. Cold ischemia time was approximately 16 hours. And overall, the surgery was uncomplicated. And then he received our standard induction with ATG 1 mg per kg times 3 and our typical 3-drug regimen of tacrolimus, Myfortic, and prednisone. So, after the transplant, the patient continues to make quite copious amounts of urine, anywhere from 2 to 3 liters of urine daily with the assistance of some diuretics, but still with no clearance, and had ongoing DGF post-transplant for which he was requiring dialysis about twice weekly. Around 17 days post-transplant, we checked to see where his anti-A titers were, and actually they were found to be quite elevated from the initial of 1 to 4 up to 1 to 128 with negative HLA donor-specific antibodies. So because of the very high levels of the anti-A antibodies, I did forego performing a biopsy at that time and decided to bring him in for therapy. So I admitted him in the end of October, about 20 days after his transplant, for empiric treatment with 5 rounds of plasmapheresis, followed by IVIG, and I actually treated him with rituximab at that time. And again, deferred the biopsy a bit longer just due to concern of the bleeding risk perplex. So during the hospitalization, his creatinine did improve from 8.9 on presentation down to 5.3. And of note, he was requiring dialysis prior to his admission and was able to come off of dialysis following this therapy. Also demonstrated improving anti-A titers that came down from the 1 to 128 down to 1 to 16 on the day of discharge. So about a week later, I opted to perform biopsy to see what we were working with.
Okay. All right. So so none of our cases are simple, right? So so this is very strongly suggestive of potentially pathology caused by these anti-A antibodies that kind of spiked in the immediate post-transplant setting. However, there was like aggressive treatment to try to clear and suppress these antibodies. And so let's see what we saw in the biopsy. So we had a good sample here. We can see mainly 2 cores and some connective tissue and vessels up in this top left over here. But we have this nice core of cortex and kind of some medulla as well over here. And right at this low power, we can see that there's a lot of pink, so that's good. A lot of well-preserved parenchyma without a lot of chronic injury. When we start looking at a little bit higher power, we can see perhaps a touch of, again, acute tubular injury. Some of these lumens are a little bit more pronounced. The glomeruli look a little shrunken, not as fully inflated as you might want to see. But here we have an arteriole that looks pretty unremarkable. Here's another vessel here that looks unremarkable. All right, so what structures are outlined over here in this field? So as you're thinking about it, I'll describe some other features here. So we can see, for example, there's maybe a little bit of chronic inflammation or inflammation in the interstitium, but there's really not anything in terms of significant tubulitis. We weren't really thinking of a cellular mediated rejection so much. And their overall, this amount of inflammation was not very pronounced, as you could see from the low power views as well. Okay, so as the votes are coming in, most are going for capillaries, and yes, these are peritubular capillaries over here. These were the very few that we saw in the biopsy that had a few circulating leukocytes, but overall, less than 10% of these peritubular capillaries had this appearance, so it didn't even meet that minimum of PTC1 in this case. So here's another glomerulus. So this one looks markedly shrunken down. You can see that there's a lot more white space in the urinary space or Bowman space. And this looks kind of ischemic. So we started seeing more of these glomeruli that had this kind of ischemic appearance. So occasionally we saw arterioles that had, a little bit of more pronounced or reactive looking endothelium. Here you can even see a little bit of this endothelial cell cytoplasm, which you normally should be pretty nondescript. And again, this is adjacent to a glomerulus that is a little bit ischemic in appearance as well. All right, so finally we get to a really abnormal looking glomerulus. So here again, you can barely see any white space in these capillary lumens. And again, this is an arteriole probably in the vicinity of this glomerulus that shows some swelling of the endothelium and narrowing of the lumen. So here's another one, pretty abnormal. We don't see any white space for the capillaries. And if we zoom in, we can see that there's material within these capillary loops. So what do you think is filling this particular glomerular capillary indicated by this arrow? Okay. Good. So no one really was fooled by this. Yeah. So this is a fibrin thrombus, and also other features that we're seeing swelling of endothelial cells as well. So they're clearly injured. There are some inflammatory cells, but this is not necessarily really the picture of glomerulitis or inflammatory cell influx. This more has the picture of fibrin thrombi, perhaps even mesangiolisis, and also endothelial cell swelling. So really along the lines of an thrombotic microangiopathy. Looks like someone's hungry too. So, okay. So that was kind of the main features that we saw by light microscopy. So we had some ischemic looking glomeruli. We could actually catch thrombi in some of these affected glomeruli. The larger vessels didn't seem to be really affected. There was maybe a touch of peritubular capillaritis, but overall not more than 10%. And there was a little bit of acute tubular injury in an otherwise generally well-preserved kidney parenchyma. So we moved to immunofluorescence, and I think the patient had originally IgA nephropathy. We did not see any IgA deposition in this biopsy. However, we did see this particular staining pattern for C4D. So based on the Banff scoring system, how should we score this? Okay, good. So this is a C4D3, and by that, what we're seeing a couple of things. So first of all, we want to see the specific staining profile outlining peritubular capillaries, and that's what we're seeing over here. All these dark spaces in between are the tubules that are negative. And so these are the capillaries that are tucked in between the tubules that are lighting up with C4D. Pretty much every capillary that we're seeing is positive. Even the glomerular capillaries are positive. And interestingly, given the history of the anti-A antibodies, we went back and tried to see whether we could actually see the IgG antibodies in the IgG stain, and we could not see them in this particular case. Though remember also this patient had been many of these antibodies were probably flushed out already by the Plex and IVIG treatment. So this would be classified as a C4D3. This is diffuse staining in greater than 50% of the peritubular capillaries. Here it's pretty much 100%.
Hey, Ram,
Yes,
could you just review D0, D1, D2, D3?
sure. Let's see. So D0 is no staining whatsoever. D1 is less than 10%. So it's not considered actually a positive C4D, but we're seeing a few peritubular capillary profiles that are lighting up. C4D2 is considered a positive C4D, and that's anywhere between 10 to 50% of the profiles labeling up with this pattern. And C4D3 is greater than 50%. So it's a little bit subjective because, we're basically looking at a dark field and trying to estimate the number of peritubular capillaries that might be staining. The way I look at it is, do I see just a few peritubular capillaries that are staining, but less than 10%? Then I call it 1. If it's anywhere less than 50%, I call it C4D2. And generally, the C4D3, the diffuse ones, are not subtle. It's pretty much labeling the entire core that we see. Okay.
Thank you.
So there was a question, I think, in the chat from Kelly. Whether the IgM antibodies for anti-ABO were also tested for, or is it only IgG?
Yeah, thank you, Kelly. Very good question. In this case, we only tested for IgG, but a very good thought. I reached out to Bloodworks, and our typical protocol is for testing is just to run tests for anti-IgG. But in reviewing the literature, IgM is certainly more common. And in hindsight, I think probably would have been a good idea to also check for those. But I don't have that data this time.
Yeah, it's a very pertinent question because it threw me off a little bit when I actually gave this diagnosis. So yeah, so clearly we have acute thrombotic microangiopathy. We have some acute tubular injury. And in the setting of the anti-A antibody, this really looks like an acute antibody-mediated rejection related to this ABO mismatch. And as Kelly was suggesting, many of these antibodies are often preformed IgMs that can actually trigger, or actually even IgGs, but that can trigger kind of a hyperacute rejection in the immediate post-transplant setting. This was now about 1 month out. And was heavily treated as well. So perhaps better to call it more an acute AMR in the setting of this anti-A antibody. We speculated whether this aggressive treatment had actually kind of dampened some of the responses that we might have seen otherwise in the tissue. For example, we did not see any IgG antibodies actually depositing, which has been reported in the literature for these ABO mismatches. We didn't see a lot of peritubular capillary congestion either. And I think the patient had already had some improvement of symptoms by the time the biopsy was done. The persistence of the C4D, again, because it's covalently linked to the cell surface, it may take some time for turnover of that complement product as well. So really, by the Banff criteria, the main thing that was positive here was C4D, which was greater than pretty much all the capillaries were positive. And there wasn't any other evidence of active inflammation overall in this biopsy.
Okay, thank you. So, as mentioned, he was actually improving since the therapy, no longer requiring dialysis. Creatinine was continuing to trend down. I continued to monitor his anti-A IgG titers, actually, which further improved down to 1 to 8 on multiple subsequent checks. Because I had treated him with rituximab, also monitored his anti-CD19 B cell levels, which were appropriately undetectable. Sorry, I'll try to, Ron, would you go advance that there?
Oh, sorry, yes.
Yep. His anti-CD19 levels were appropriately undetectable. Showing me that rituximab therapy was at least working. His creatinine continued to improve. As I mentioned, it was in the 8s previously and had come down to the high 2s to low 3s at that time, with some improvement in proteinuria. He had as much as about 1.8 to 2 grams, came down to about 1.1 to 1.2 grams. However, on subsequent checks, his anti-A titers began to rebound. And I watched them for a while as his kidney function was fairly stable, but then they rose to about 1 to 32 with a bit worsening proteinuria, which point I became a bit concerned. At that point, I opted to repeat a biopsy at about 1 month from the initial biopsy and about 2 months out from the transplant.
Thank you. And there's a comment also from Nikolai. He wonders whether we should be even calling this acute or hyperacute rejection with no inflammation, and if the C4D was not positive, what we would have called it, expecting that we were going to see some degree of C4D staining since this is an ABO incompatible allograft. So yes, so Nikolai, so that's why I didn't call it a top line as a acute cellular rejection, right? I called it as acute thrombotic microangiopathy. And even though there wasn't inflammation, there was severe injury to the vasculature and the thrombotic microangiopathy. Unfortunately, we didn't have a good sample for EM. There were no glomeruli, so we didn't do EM on that case, or actually even in the subsequent one that I'm going to show you as well. But the thought here was that the antibody was actually causing the injury to the glomeruli. There was C4D that was positive that has been associated with these anti-A antibodies, and we had acute tubular injury as well. So that was kind of the thinking from the first biopsy.
And I agree completely, Ram. I kind of want to make another argument just for the sake of actually thinking outside of. It seems like we are putting a lot on that C4D, which is expected in this case, right? And the vessels are not really that injured. You mentioned vessel injury. I think most of the clots were in the glomerular vessels, right? So the capillaries.
Yes.
Yeah. So the vessels were actually unremarkable, which is another point that we do see, as you know, sometimes we see these clots in the glomeruli with worm ischemia, even sometimes.
This is a 1 month out though, right? So and it wasn't just a clot. There was actually endothelial cell swelling in there
we
too.
would expect that, right? So anyway, yeah, just trying to make an argument that I think if the C4D was not positive in this case, then I'm not sure if this would be so easily called hyperacute rejection, and that may be a kind of a bystander finding in the context of A2B. But again, just trying to make an argument here.
Yes, sure. I'll show some studies which are suggesting that these are difficult because these patients have CNIs on board. There's other risk factors, and then of course with the ABO incompatibility, they've got now much higher risk for an AMR, and the AMR can actually manifest as a TMA. And so I'll show you some studies describing the increased incidence of that. So again, I think the way I looked at this was whether we call it an AMR or not. Here, the endothelial injury that we were seeing, which was manifesting as a TMA, was, to me, in my mind, most plausibly attributed to that elevated anti-A IgG titer. So Daniel was already treating it as such and to try to remove it and suppress it. And so let's see what happened in the second biopsy. So in the second biopsy here, we have a couple of really more or less normal looking glomeruli. So we didn't have as pronounced as a TMA in these two glomeruli as we had seen in the previous biopsy. However, there were some additional changes. So rare glomeruli showed influx of inflammatory cells, which were occluding the capillary lumen. There was also some distortion and perhaps duplication of glomerular basement membrane contours in some of these capillary loops. And so there's a touch of glomerulitis and maybe even some early changes that we could think about calling transplant glomerulopathy as well. These were not widespread, but they were present. There was a little bit more of chronic injury to the tubulointerstitium. If you recall, the first biopsy looked pretty pristine. However, since that injury, now 2 months in the post-transplant setting, there seemed to be a little bit more chronic injury, still on the mild side. Still could be dependent on sampling, but this was a little different than the prior biopsy. Occasional glomeruli also showed this kind of change over here in this lower right. And you could see that there's some occlusion of these capillary loops by these reticulated foam cells. So there's kind of a de novo now FSGS also developing. So really what we're saying is that the TMA was not as pronounced. There was some changes of perhaps evolving FSGS and capillary wall remodeling in the vein of an early transplant glomerulopathy. C4D remained positive. Now, so this is 2 months out with intensive pheresis and suppression of the attempted suppression of the antibodies, but C4D was still positive 2 months out after that. So I think Behzad, I think actually you saw this one. So this was called acute antibody-mediated rejection. You know, that we noted again the diffuse C4D that was present and persistent. Now there was also a little bit of glomerulitis. There was maybe some early transplant glomerulopathy changes as well, and some FSGS. Overall chronic injury was a little bit more. And again, unfortunately, we did not have a good sample for EM, so we weren't able to do that.
Okay. And thank you, Nikolai. Your points are definitely well taken, and I think it's a difficult case, and but faced with kind of what what we had in front of us, I opted. So I opted to after the subsequent biopsy, because he did have some ongoing inflammation, I did opt to pulse him with steroids, and because of the rising titers, I did plex him on 3 different occasions, followed with IVIG, and opted to pursue therapy with daratumumab. An IgG, a monoclonal IgG antibody targeting CD38 to try to deplete these plasma cells that are producing these ongoing anti-A titers. And so he received 8 doses of this 16 mg per kg given weekly, and recently completed about 2.5 weeks ago now. As part of the therapy, it was relatively uncomplicated. He received pre-meds with Solumedrol and Benadryl. Tolerated well, with the exception of some pretty significant nausea during the first infusion that improved with slightly increased dose of steroids and addition of antiemetics, and also had some ongoing neutropenia that required Neupogen just on, I think, 3 occasions during the course of his therapy. Subsequently, his anti-A titers did improve down to 1 to 4 following Plex, and have maintained and remained low with the most recent level of 1 to 2 from the end of March since completing the daratumumab therapy. He did have a creatinine nadir, though still elevated. Best creatinine for him has been about 2.3, though with the most recent one of 2.4. He is now approaching the 6-month mark post-transplant, at which point, and now, assuming no rapid improvement in the creatinine at that time, I think sort of the route I'm going to take is probably repeat his biopsy shortly. And if reassuring from a rejection standpoint, and also by the way, I should say his cell-free DNA markers have all been quite low. Highest was 0.4% on AlloSure back around the time of the second biopsy, but most recently has been 0.09 as of mid-March. And again, as I mentioned, no HLA DSAs present. So I may pursue belatacept in hopes of further improvement in his creatinine.
Cool.
A difficult case, I'd say.
Yeah, very challenging case and kind of an unusual presentation. And I think it's interesting that the patient really never had any anti-HLA DSAs, right? And it was only just this anti-A IgG, and we don't know about the IgM status either. So yeah, I thought this
Ram, if I can just make a quick comment. Daniel and I have talked multiple times during this case, and I completely agree with the management. My comment was not by no means questioning what's been done, and I would have done the same thing, and I applaud Daniel for actually bringing these new tools to the treatment of this patient. It's just that I think we should think critically now that we have a retrospective view of how things have actually evolved with controlling those antibodies, and doesn't seem like much has changed. So I just wonder. I think kind of I want us to challenge ourselves to think and really see if indeed this was the process that was causing this damage, because I think it's very hard to prove that this was not just some type of bad outcome that happened in the OR in the recovery of that kidney, and maybe compounded with the long cold ischemia time that this kidney experienced. And so yeah, that was the purpose of my comment. I just
Oh,
want
no, yeah, no, I think, and that's why I wanted to present this case also from a pathology perspective. Nikolai points are very well taken. I
Absolutely.
think, you know, the way I think, yeah, the way I look at this is that, you know, it's hard to ignore that the high titer antibodies that were present, right? And there was a correlate in the second one. Of course, there was a little bit more inflammation, still not a lot compared to the first biopsy. Um, it's interesting that the cell-free DNAs were always low, right, Daniel? That's what you mentioned, that they were never above the 1% threshold.
Correct.
But the inflammation, the injury that we were seeing is not quite the way we would expect, you know, with the extensive microvascular inflammation associated with the high cell-free DNAs. So yeah, so there are some questions here, right? Um, it's a hard one to test here because we've got to try to keep that anti-A antibody suppressed. If it at any point, if it recurs and are correlated with you know, pathology in the allograft, then I think we could plausibly ascribe it as being pathogenic there. But the sum total of evidence that I'm seeing so far, I'm still favoring that these antibodies were actually pathogenic, actually causing endothelial injury in an acute fashion. But at least the patient is improving, and that's the most important thing. So just briefly, you know, ABO incompatible transplants. This is one of the first reports, I believe, of this. And so, of course, because we're crossing these blood group antigens, there's always a risk of rejection. And this is the more typical definition of hyperacute rejection in this initial study where they transplanted these organs, and most of the patients experienced immediate, you know, graft modeling and dusky appearance, as you might expect from preformed antibodies depositing and causing injury. Now, of course, in the subsequent years, we've learned a lot about this in terms of trying to improve our induction protocols to desensitize these patients with either B cell depleting or now plasma cell, perhaps depleting therapies, removal of the pathogenic antibodies, reconstitution with IVIG, or even more expensively trying to absorb these antibodies and remove them from the circulation. And as we've seen in this case, I think the goal, my understanding at least, is to try to keep these low to try to prevent allograft injury and loss. And of course, the whole reason for trying to go through this potentially a serious incompatibility is to increase the donor pool, right? So, and ABO incompatible allografts are a sizable fraction of the general transplant procedures, and definitely so in Germany, Japan, and other countries as well. So, you know, if we were to think, okay, what's the overall outcome of ABO incompatible allografts versus just compatible, you know, where we're not crossing a major blood group antigen barrier. And so this was a nice meta-analysis that was done just a few years ago, where they looked at almost 1,400 ABO incompatible allograft patients compared to almost 5,000 compatible patients as well. And they noted that, you know, 1 year graft and also overall patient survival was just slightly lower for the incompatible allografts. And by slightly, I mean 98, 99% compared to 100% for the ABO compatible group. So not a huge difference, but it was definitely significant. And the major problems that were at higher frequency in the AB incompatible patients were, of course, infection. This may be related to some of the increased suppression. The plasmapheresis is also going to like remove potentially protective antibodies. The plasmapheresis has also factored into Daniel's consideration about bleeding risk and clotting factors. That's also another complication that is at a higher frequency in this group. And interestingly, both rejection and antibody-mediated rejection, especially, are at a much higher frequency that is seen in the ABO incompatible allografts compared to the ABO compatible patients. Now, digging into this a little deeper, we can see where this relative risk is coming. So across all of these studies in this forest plot, you can see that the trend is clearly for an increased relative risk, almost fourfold compared to the ABO compatible allograft cohort. Now, specifically thinking about, this thrombotic microangiopathy, and can we blame it on the anti-blood group antibodies, or could it be due to some other factor, right? And so this was a group study published by Tibor Nadazdi and colleagues a few years ago. And so here they wanted to try to examine this in a little bit more detail. And so they collected patients with and examined which ones had thrombotic microangiopathy in the histology, and also connected them with the presence of PRA, or actually even donor-specific antibodies. And they were also looking at whether the peritubular capillaries were labeling positive or negative for C4D. So in this cohort where they had PTC positive C4D staining, they saw about 33 patients also presented with thrombotic microangiopathy. And of these, 50% of them had a detectable donor-specific antibody, mostly targeting, and 80% of those had mostly targeting class 2. And so again, there's potentially a role for these pathogenic antibodies contributing to TMA. And this was mostly seen within the first 6 months, which is the time window where we're talking about for this patient as well, associated with thrombotic microangiopathy, mostly in the glomeruli, rather than injury in the other larger vessels or even peritubular capillary congestion as well. So I think there are some similarities with this particular patient, and it'll be very interesting to see what's going on in the 6-month biopsy, and whether those blood group antibodies rebound at any time in the future. Okay. So we'll stop there. We're a little over time here, but if there are any burning questions, we can try to address them. So very challenging and interesting case, brings up a lot of concepts, I think, for us to learn about and learn from this experience. So looking forward to seeing the next biopsy, Daniel, whenever you get to it.
Sure. Thank you so much, everyone.
All right. Thank
Well,
you all.
thank you, Dr. Akalesh and Dr. Douglas. Some really great presentations today. For everyone who's participating in spring break next week, enjoy. For all of us, Nephrology Grand Rounds is held for next week, and we'll see you on the following week on Zoom. All right, have a good weekend. Bye.